Hello, I'm Dr. Elaine Wirrell, and on behalf of CME Outfitters, I would like to welcome you to today's educational activity titled Global Perspectives on Diagnosis and Management of Childhood Epilepsy Disorders, with a focus on Dravet, Lennox-Gastaut, and tuberous sclerosis complex. Today's program is supported by an educational grant from Jazz Pharmaceuticals. This continuing education activity is brought to you by CME Outfitters, a jointly accredited provider of continuing education for clinicians worldwide. I also want to encourage everyone to join us today on our live Twitter conversation at CME Outfitters. We will be monitoring the Twitter feed and responding to the Q&A portion of this program. So again, I am Dr. Elaine Wirrell, and I'm Chair and Professor of Child Neurology at Mayo Clinic in Rochester, Minnesota, and I'm delighted to serve as moderator for today's program. Today, I'm joined by an esteemed panel of expert faculty who are now going to introduce themselves.
Hi, everybody. I'm Tracy Dixon-Salazar. I'm the Executive Director of the Lennox-Gastaut Syndrome Foundation based out of San Diego. I also have a PhD in cellular molecular neuroscience, which I use in my position at the foundation. And I also have a 30-year-old daughter, Savannah, who has Lennox-Gastaut syndrome, and it's great to be here.
Hello, I am Samba Reddy, Professor of Neuroscience and Experimental Therapeutics here at Texas A&M New Step School of Medicine. My research focuses on developing anti-epileptics and elucidating the mechanism of action of anti-epileptics, and also to study the pathophysiology of epilepsy.
Hi, I'm Strzelczyk from Germany. I'm a consultant neurologist and intensivist at the Epilepsy Center, Frankfurt Rhine-Main. And one of my major research topics are health economic and outcome research in developmental and epileptic encephalopathies. And I'm really happy to be with all of you today.
Hi, everybody. My name is Bethany Thomas. I'm a nurse practitioner at the Penn Epilepsy Center in Philadelphia, Pennsylvania. And in this role, I also coordinate transitions of care for patients from surrounding pediatric centers into our adult center, and also very happy to be here tonight.
Well, thank you, everyone, and welcome. So I think we've got an exciting program tonight. I'm going to go to our first learning objective. So our overall goal today is really to improve the outcomes and quality of life of patients with early onset epilepsy disorders and their families. And so the first learning objective there is to really be able to achieve an early and an accurate diagnosis of early seizure disorders, including Lennox-Gastaut, Dravet syndrome, and tuberous sclerosis. And I'd like to talk a little bit first about the definitions of developmental encephalopathy, epileptic encephalopathy, and developmental and epileptic encephalopathy. So if we talk about a developmental encephalopathy, that really implies that the developmental impairments that that child has is due to the underlying cause of the epilepsy. So it's due to the monogenic change in all of the cells, or it's due to a diffuse structural change or things like that. And if we say this is a developmental encephalopathy, what is implied is that the epilepsy itself, the frequent seizures or the epileptiform discharges, are not contributing to impairment. So even if we improved seizure control, we're likely not going to significantly improve that developmental impairment. In contrast, epileptic encephalopathy really implies that it is the epileptiform discharges and the very frequent seizures that results in the cognitive and behavioral impairment. And so if somebody has an epileptic encephalopathy and we do a better job of getting those seizures under control, that is not only going to just improve the seizures, that's really going to improve that child's development and potentially behavior. In reality, most of the developmental and epileptic encephalopathies that we talk about in childhood have really both of those factors. So there's usually some type of an underlying cause that leads to some degree of encephalopathy. And then in addition, these children have very frequent, often drug-resistant seizures, a very abnormal EEG with lots of discharge. And that also contributes to the encephalopathy. And if we think about the developmental and epileptic encephalopathies, these account for about a third of all new onset epilepsy in infants. So quite a significant proportion there. And studies have shown that about 1 in 2,000 infants will develop a developmental and epileptic encephalopathy within the first 2 to 3 years of life. So these are actually quite common conditions. And when we think about the early onset developmental and epileptic encephalopathies, we can think about those related to specific etiologies that may be associated. So certain structural etiologies like a hypothalamic hamartoma or a diffuse brain insult, or we can think about that in terms of specific epilepsy syndromes. And you can see here, epilepsy syndromes are really divided into sort of the typical age of their development. So an early infantile developmental and epileptic encephalopathy that comes on always before 3 months of age, sometimes even in the neonatal period. The former names that were used for that were things like Ohtahara syndrome and early myoclonic encephalopathy. So this is a new name that really encompasses both of those. In infancy, probably the most common DEE is infantile epileptic spasm syndrome, formerly known as West syndrome. But another one that is also quite common and important to recognize, and we'll be talking about in a bit more detail today, is Dravet syndrome. And then as well, epilepsy in infancy with migrating focal seizures, that typically comes on usually again in the first 3 to 6 months of life. So very, very early with interesting seizures that really start in one hemisphere and often migrate around the brain to different sites. So very unique EEG picture. And then in early childhood, Lennox-Gastaut syndrome. And Lennox-Gastaut syndrome, it's not an uncommon cause of drug-resistant epilepsy, but sometimes it can be a little bit challenging to make that definition early on. And studies have shown that on average, it takes about almost 2 years before all of the criteria for Lennox-Gastaut syndrome are present. So sometimes it can take a little bit to be sure that that is the right diagnosis. And then other syndromes that can be associated with DEE are DEE with spike wave activation in sleep. They used to be called Landau-Kleffner syndrome or CSWS or ESES, epilepsy with myoclonic absences, and then DEW syndrome or epilepsy with myoclonic atonic seizures.
Yeah, so we have 3 well-defined syndromes. I'm starting with the Dravet syndrome with a typical presentation around the age of 6 months. The underlying etiology is in the vast majority a pathogenic variant in the sodium channel structure. It's the STN1A gene. And typically these children present with febrile, sometimes afebrile, but mostly febrile seizures, which are also sensitive to vaccinations. And then over time, other seizure types appear over the time, including atypical absences, myoclonic and atonic seizures. Usually, diagnosis is made until the age of 20 months of age, as outlined by the ELIE, but most of the patients will already present between 6 and 12 months of age. Be aware, if the onset is earlier than 3 months, that's a red flag that something else might be there. Then obviously another genetic condition is the tuberous sclerosis complex. It's caused by a mutation in TSC1 or TSC2 gene. They're both very important in the mTOR signaling, and this plays a part in cell size development and proliferation. What's typical from the seizure point, it's infantile spasm or focal seizures, and it can allude into focal to bilateral tonic-clonic seizures. Usually with an early onset, you see this epileptic encephalopathy, but you have also patients with later onset seizures in early adolescence or adulthood. Very importantly, you will have other signs. So you can have multiple benign tumors, so-called hamartomas, especially in the brain, eyes, skin, kidneys, heart, and the lungs. In heart is very important on ultrasound. Sometimes you can see cardiac rhabdomyoma indicating of TSC before birth. And then, as Elaine said, we have also the Lennox-Gastaut syndrome, which has variable underlying etiologies. You can have a structural brain abnormality, but also normal MRIs with genetic background. These patients suffer from multiple intractable seizures, including tonic and usually other semiologies like generalized tonic-clonic, atypical absences, atonics, and spasm. Typically on EEG, you will see some diffuse slow spike and wave pattern. And very importantly, it can take some time. Most of the patients will present with a full type until the age of 6 or 8 years, but you can make the diagnosis up to the age of 18.
All right, so let's move on to a patient case. So this is little Ella. Ella is now 11 months of age, and she comes in because she's having some ongoing seizures despite treatment. Now, her history, she had a pretty normal pregnancy and delivery, according to mom. And she was delivered a little bit early at about 35 weeks gestation, but was otherwise well. She was very well, in fact, until 8 months of age. And at 8 months of age, she developed RSV. And her mom reported when she was having fever that she would have some shivering episodes with fluctuating alertness, and nobody really made much of that. At 9 months of age, she presented with a first clear seizure to the emergency room. She was febrile at the time, and the seizure began with left hemiclonic activity and progressed to bilateral tonic-clonic activity. And that was quite a prolonged seizure. It lasted about 25 minutes. The EEG was done the following day, and it did not show any epileptiform abnormalities. Her exam was completely normal. Her initial labs, glucose, electrolytes, CBC, things like that were all normal. And so it was felt that she had had an atypical febrile seizure, a prolonged febrile seizure. And so she was prescribed rescue diazepam and was sent home. The following month, however, she went into her pediatrician, and this time she presented with a right-sided hemiclonic seizure, so the opposite side of her initial seizure, and that lasted about 15 minutes. And following that, she was started on levetiracetam. She underwent a number of investigations, including an EEG, an MRI, and as well she had CSF studies, and all of those were within normal limits. So the next question for little Miss Ella, what investigation should be performed to identify the etiology of her seizures? So I'd like everybody to vote and let me know what they would like to do. So one option is a genetic epilepsy panel. The second is continuous EEG monitoring. The third is a PET CT. The fourth is looking for autoimmune causes, or the fifth, I'm not sure. So we'll let people go ahead and vote. All right, so we've got quite a mix of responses here. So a third of you said a genetic epilepsy panel, a third of you would do continuous EEG monitoring, and a third of you were not sure, and that's okay to not be sure, that's why you're here. So in fact, for young children with onset of seizures, particularly with worrisome findings like a prolonged seizure or with some developmental concerns, a genetic epilepsy panel is really, really important and very, very high yield. And in fact, many people are now thinking that a genetic epilepsy panel for such children is as important as doing an MRI. So the correct answer here is a genetic epilepsy panel. A continuous EEG and a PET CT, those are things that you might want to do if you were concerned that somebody had a drug-resistant epilepsy and maybe there was a surgical option, a resective surgical option. But we know for Ella, she had seizures that initially affected her left side and then affected her right side. So the likelihood that she would have a single focus that one could operate on would be very, very low. So the correct answer here would be a genetic epilepsy panel. And we would expect that we would likely find a pathogenic SCN1A variant. So we'll talk a little bit about the diagnosis of Dravet syndrome. Here is a diagnostic algorithm. And so Dravet syndrome is a syndrome that typically presents in the first year of life, sometimes even up to 20 months, but typically in the first year. and it affects children who are previously developmentally normal. So a lot of times this diagnosis is not thought about because people think, oh, they should be abnormal. But in fact, at the time they present, they are developmentally normal. And they present with focal or generalized convulsive seizures. Characteristically, those seizures are often prolonged, and they can go on to status epilepticus. They can also present with brief recurrent hemiclonic seizures. So sometimes they're prolonged, sometimes they're briefer. Very characteristically, they are fever sensitive. And oftentimes these children will have seizures that relate to a vaccination. So they'll have a routine vaccination, and then typically when they get febrile after that vaccination, they'll actually have their first seizure. And one of the very characteristic clues is this switching sides, right? So a child who comes in with a prolonged right-sided seizure, and then the next seizure they have, several weeks later is now on the left side. The usual investigations that you do are normal. So typically we would do an MRI, we would do some lab studies looking at glucose and electrolytes and things like that. Oftentimes these kids do get CSF studies because they present with a prolonged focal seizure with fever. So there's concern about infection, and all of those are normal. And so really we want to be thinking about doing the genetic testing early. Most of the time we do this using an epilepsy panel because that looks for a large number of genes, and next generation sequencing is probably the way to go. And there are a number of panels that are available commercially. A few alerts here: if you have a child who does not have fever sensitivity, or a child who actually is treated with something like oxcarbazepine or carbamazepine and responds very well, that would be a clue against Dravet syndrome, because usually the sodium channel agents worsen that. And also exclusionary if you had a history of epileptic spasms or focal lesions on MRI, that's also against the diagnosis.
Yeah, now we come to another case of the 20-month-old male Kai. And so here's some developmental delay already and possible seizure. The development was normal until that time. He made some verbal noises by no expressive language. He crawls, scoots, and stands with support, but not yet independently walking. And parents are reporting multiple episodes of staring spells. So you are already suspicious atypical absences or focal dialeptic seizures. On physical exam, this reveals two hypopigmented macules on the trunk. You will see it on the right upper part, and they are ovoid 1.5 centimeter in diameter, and obviously no signs of scalar inflammation on that, and no color change when pressed. Sometimes it's quite useful to use a wood lamp to see better changes on the skin. So this is also a possibility to have a better look on the skin. And obviously, you should also look at the eyes, and this shows bilateral retinal hematomas. And on the examination, you see some mild spasticity in lower limbs. So you suspect TSC, obviously on clinical grounds, and obviously you will continue with an EEG and an MRI. And now I pass to Elaine for the questions.
All right, thank you. So the question for the audience then is, what finding would confirm a diagnosis of tuberous sclerosis complex in Kai? So would it be temporal sharp waves on EEG? Would it be a hypsarrhythmia on EEG? Multiple cortical tubers on MRI? Hippocampal atrophy on MRI? Or not sure? So if the audience could go ahead and vote. So which finding would confirm a diagnosis of tuberous sclerosis complex? All right, great. So it looks like most of you had chosen multiple cortical tubers on MRI, and that is indeed the correct answer. So these children often do have abnormalities on EEG, so temporal sharp waves, but that's not specific for tuberous sclerosis. Some of these children can present with infantile spasms early in life and may have hypsarrhythmia with that, but again, that's not specific. But if we see those multiple cortical tubers, that's one of the diagnostic criteria that we see. So I'll hand it over to Adam, and he can talk a little bit about the diagnostic criteria.
Thank you. So I think first to get sure, it's a clinical diagnosis which you can make. Obviously, a definite TSC can be confirmed by genetic criteria in TSC1 or TSC2 gene, but usually it's enough to have two major features or one major and two minor clinical features which are indicating TSC. And then obviously you will have cases of possible TSC only with one major feature or more than two minor features without other points. Very importantly, features like angiomyolipomas and LAM are major features that will present later in life, so you will not be able to see that in early childhood. So what are major features? These are more than two cortical tubers, and then hypomelanotic macules on the skin, ungual fibromas on the hands, retinal hematomas, shagreen patches usually on the forehead, then cardiac rhabdomyoma, which you can already see on prenatal ultrasound, then obviously subintimal giant cell astrocytomas on MRI scans, subintimal nodules, angiofibromas, and angiomyolipomas and LAM, which usually present later on. And other minor features, usually confetti skin lesions, dental enamel pits, intraoral fibromas. You should look at the eyes, the retinal achromatic patches, and renal cysts, sclerotic bone lesions, and non-renal hematomas. Very importantly, even if the DNA test is negative for a pathogenic variant, this does not exclude a TSC diagnosis. And in clinical practice, always have a look at both parents and siblings, as they might also suffer from TSC with a much milder phenotype, which was not recognized yet.
Thank you. And Adam, you can make the diagnosis just on the genetic findings too, right? If you have the genetic findings, yeah. All right, so I'd like to next present the case of Sam. So Sam is 3 years old, and she is presenting to you with frequent intractable seizures despite treatment. She was diagnosed with West syndrome or infantile epileptic spasm syndrome at 8 months of age. And at that time, her EEG showed clear hypsarrhythmia. She had undergone neuroimaging. She had had genetic testing at that time, and no clear etiology was found. And Sam has had a pretty tough time with her seizures. She has failed multiple anti-seizure medications. She did achieve about a 50% reduction with clobazam, but never seizure-free. And her parents are reporting new episodes of unresponsive steering in recent months. She also has what they feel look like the infantile spasms, but these are now lasting longer. So they call them tonic spasms still, but these are now lasting even a couple of minutes instead of seconds. In addition, she has moderate developmental delays on exam. She has limited ability to communicate. She is not able to walk independently. And her EEG shows diffuse background slowing. And as you can see here, she has this generalized slow spike and wave complexes that are about 2 to 2.5 hertz on her EEG. And so the next question again for the audience is, which of the following signs and symptoms is most supportive of a diagnosis of Lennox-Gastaut syndrome for Sam? So is it the fact that she has moderate developmental delay, that she has unresponsive staring episodes, that her EEG background shows diffuse slowing, that she has generalized slow spike and wave complexes, or I'm unsure? So which of those do you think would be most supportive of a diagnosis of Lennox-Gastaut syndrome for her? All right. So again, a very sophisticated audience. The majority of you chose generalized slow spike and wave complexes. And indeed, that is the correct answer. So that is a supportive finding for Lennox-Gastaut. Children with Lennox-Gastaut often will have diffuse slowing on their EEG, but again, that's not specific. They can have atypical absences. They are generally children who have at least moderate degrees of intellectual disability as well. So let's go through the diagnostic criteria for Lennox-Gastaut syndrome. So there are some mandatory criteria, and the mandatory criteria are these tonic seizures. And the tonic seizures sometimes can be a little challenging to know that they're there because they can be a little bit more subtle, and sometimes they are seen only in sleep. And so unless the parent is actually sleeping with the child, they may miss those. In addition to tonic seizures, though, they have at least one other additional seizure type, and in most cases, they have many other seizure types, including drop seizures or atonic seizures, atypical absences, myoclonic seizures, generalized tonic-clonic, focal impaired aware seizures, epileptic spasms, and many of these children will also have recurrent bouts of non-convulsive status. The EEG has two very characteristic findings. The first is that generalized slow spike and wave. And so this is spike wave that is less than 2.5 hertz, and therefore looks very different than the spike wave we see with typical absence epilepsy, which is 3 hertz or more. And then in addition, they also have what we call generalized paroxysmal fast activity. And that is seen predominantly when they sleep and often correlated with tonic seizure activity. So there's a number of sort of alerts that you would need to look for, and that you might consider other diseases. So if you do a photoparoxysmal response on EEG at low frequencies, sort of 1 hertz or 3 hertz, and you see that, you want to be thinking about Batten disease. Many of these children will kind of take some time to evolve, as I had mentioned. So sometimes it can take even up to a couple of years to recognize that they clearly have Lennox-Gastaut syndrome, although you certainly suspect they're going in that direction. So exclusionary would be persistent focal abnormalities without a generalized spike and wave pattern. And importantly, Lennox-Gastaut, there's a lot of different causes. So you don't actually need to have neuroimaging or genetic testing to make the diagnosis, but those are really important tests to do to look for the underlying cause and potentially to guide treatment. So we're going to switch gears a little bit, and we're going to look at how we can best manage these early onset epilepsy syndromes, really focusing on quality of life. And we're very fortunate to have Tracy Dixon-Salazar with us today, who is going to give us a bit of a story of her lived experience. Tracy, go ahead.
Thank you so much, Elaine. Yes, so I'm going to tell you a little bit about our daughter's journey. She was typically developing until the age of 2.5 when she had her first seizure. And this is true for about 1/3 of kids with Lennox-Gastaut syndrome, that there's no previously identified issue with them in terms of development. She did have an etiology that we did not know about that was going on, which I'll talk about in a minute. And then she had her first seizure at the age of 2.5. It was a tonic-clonic. We had no idea that she was having a seizure. We thought she was choking. And then she had a couple of more seizures. She had 3 more seizures over the next couple of months, and then went 6 months without having any seizures at all. And we thought, dodged a bullet there. But by the time she was 3 years old, the seizures came back. They came back with a vengeance. EEG ultimately ended up picking up 6 different types of seizures, including myoclonic, atypical absence, spike wave stupor, atonic, all of many of the generalized seizures, no focal activity. And then we started her on treatment at the age of 3, and she very swiftly developed treatment-resistant epilepsy, which was her diagnosis for a long time. So everyone with LGS has a diagnosis of epilepsy, or in most cases, treatment-resistant epilepsy. And this is really when the developmental delay began to emerge, is when the seizures came back at the age of 3. And, she had this abnormal in-between interictal seizure activity, this epileptiform activity. She was having hundreds of seizures a day at this point, and the interplay of that plus her developing brain ultimately led to her getting the diagnosis of Lennox-Gastaut syndrome when she was 5 years old. It's happening a little bit sooner in these days and ages because this was 30 years ago. She's 30 years old now, which I'm going to talk a little the rest of her journey. But this is the point when the slow spike in wave and the generalized paroxysmal fast activity turned up. And it's really a sign that something has gone horribly wrong in brain development for these kids. And, you can have tuberous sclerosis complex mutation that evolves to also develop Lennox-Gastaut syndrome and many, many other genetic or acquired forms of epilepsy. From that point, she was, let's see if I can advance to the next step. So here she was at 5 years old, and between the age of 5 and 18 years of age, she had more than 40,000 seizures. It took her 3 years to get the LGS diagnosis. It took another 15 years to find her etiology. It took us a total of 7 neurologists back then to get to the LGS diagnosis, many hospital treatments, many hospitalizations, many rescue medicines. I mean, by the time she was 18, she was going into non-convulsive status 2 to 4 times a week. We were in the hospital frequently, many, many surgeries, very, very expensive. And she had tried and failed 26 different types of treatments, including medications, diets, and devices. And at that point, she's really just racking up diagnoses. She's got LGS, she's got DEE, she's got intellectual and developmental disability, she's got intractable epilepsy, with unknown etiology. Thank God we got rid of, cryptogenic, idiopathic, or I can throw that here. And she has this very abnormal brain network, which, we believe is what really, the LGS is what really just stopped her learning and her developing. And this really led to, I think, a broader impact over the rest of this time, where she then developed, there were the seizures all the time. Like I said, there were the clusters in the status. There was also the fear of SUDEP. She would get aspiration pneumonia a few times a year, many ER visits. And then over time, brain matter atrophy. But then all of these LGS associated disorders started to emerge, right? And it's basically can be summed up with her having a complete and total inability at the age of 18 to navigate the world effectively. She would go off with a stranger, she would turn the oven on and burn down the house. She'd cross the street without thinking about it. She'd go outside naked. I mean, all of these things. So lots of behavioral issues, which I've defined here. Academic issues. By the time she was 18, she didn't read or write. She spoke like a 2-year-old. She had quite advanced language, but her speech intelligibility was very young. Memory issues were intense. She was thought to be functioning at an age of about a 2 or 3-year-old cognitively. Mobility issues, she basically couldn't dress, toilet, or feed herself. Sleep issues, including sleeping all day, not sleeping at night, sleeping all night, not sleeping, excessive nighttime waking, tonic seizures. And then there's all these other issues that emerge: constipation, which most of our LGS families have, low bone density, social isolation, weight loss, liver issues, hairiness, excessive gum overgrowth. And this goes on to impact the whole family. So when you think about, quality of life in Lennox-Gastaut syndrome, this is really what you guys remember Maslow's hierarchy of needs from psych class. This was really our hierarchy of needs. We had a very low quality of life when she was in crisis. So this was seizures, status epilepticus, pneumonia, and we're just surviving in survival mode. And if, and then there was and if you remember when COVID hit and we were all just sitting around wondering what was next, that's what survival mode feels like. Then, if she wasn't in crisis, we were just trying to avoid crisis. She eating, sleeping, drinking, going to the bathroom, taking her meds, breathing. And that's just safety mode. And then above that, avoiding crisis, unassisted by caregivers is sort of what I would call coping mode, which is what we're in now. And I'll talk about that next. But that's where she does do any of those things independently. And still at the age now of 29, she just turned 30. So the slide's already outdated. She's not doing any of those things independently. Savannah was a success story, though. At the age of 18, we did whole exome sequencing on her, and she has calcium channel mutation, so calcium channel overactivation disorder, where too much calcium is going in through L-type calcium channels. We actually put her on a medicine that's used off-label in epilepsy at times, and it's used for high blood pressure and arrhythmia. It's calcium channel blocker called verapamil. And we had an amazing 95% reduction in her seizures for 11 years and a 99% reduction in her status. She started learning again, and she now functions between a 3 and 7-year-old. But, during that time, and even to an extent today, what we really see when you think about quality of life is that the unpredictability of the seizures and that unpredictability that has on your child, but also on life. Can you go to work? Can you go to school? That frequency of the seizures. So we're not talking like 1-2 seizures a year. We're talking like 1-2 seizures an hour or a day in many, many cases. And I think this is what sets LGS apart from from things like tuberous sclerosis and Dravet is the seizure burden tends to be much, much higher in the thousands across a 6-month period is what the REN study showed versus hundreds. And then the severity, the aspiration pneumonia, the ER visits, that leads to this chronic traumatic stress disorder, not post-traumatic stress. There's no post. And then that then leads to these secondary consequences of inability to make plans, managing complex medical issues. It's a full-time job to manage all of this. Isolating ourselves at home because we don't want to go out in the world. And then that leads to even further complex issues where you have this constant stress overload on the entire family. The whole family is sleep deprived. So you have the child's issues, and then those just become compounded and compounded and compounded. And so when we think about quality of life, we're just surviving in life. We're not thriving. And oftentimes we see when people come and talk to us about quality of life, they're like, how are they interacting with their peers? And we're like, what peers? We haven't left the house in, months because there are just so many seizures and the medical emergencies are very frequent. So that's been our journey. Savannah, continues to learn and grow, which we're very, very thankful, but that is not the case for most with LGS. But I think it just shows that you never want to stop looking. With that, I'm going to turn it over to you, Bethany, and you can talk a little bit more about quality of life here.
Thank you, Tracy. I think that you did such an excellent job at highlighting a lot of what I wanted to talk about with this slide. I think that we've all seen in treating our patients that there are so many different factors that can affect the quality of life of individuals and their families who are living with developmental and epileptic encephalopathy. Certainly seizure burden is the most critical factor impacting quality of life, but it's certainly not the only one. Oftentimes the treatment priorities and the overall goals of care will shift as a patient ages. Certainly an anti-seizure medication burden and the adverse side effects that medications can cause can also negatively impact patients' quality of life. And so oftentimes as care providers, we're trying to find that balance between the seizure control and adverse effects of any of these treatment options that we can provide. Also important to keep in mind that nearly all patients with developmental and epileptic encephalopathies are medically complex and will have multiple different comorbidities. The medical health comorbidities such as ADHD and behavioral changes pose unique challenges for this patient population. And there are additionally psychosocial complexities, like Tracy mentioned, such as these patients having various levels of functional capacity, which can change over time, trying to optimize their own independence, social stigma, and all of these things can impact not just the patient, but their family and their care team. And so for us as care providers, it's really imperative to acknowledge and address all of these issues and not just the seizure burden or not just the seizure medications that we're using to treat these folks. And in order to provide this high quality care, it's really important to utilize team-based care. So in several of these practices, we like to use a physician care team alongside advanced care practice providers, social workers, nurses, psychologists, and other professionals who can really help to address all of these issues, manage different pieces of this, and with the overarching goal to improve the quality of life of the patients and their families. And then you can see the bar along the bottom there. Transition of care is always on our mind. I work in an adult center, so I think this is something that we always think of for patients that we're bringing into our center. And certainly transition of care for a patient that's so complex is often a source of anxiety and stress for both the patient and their families. And it's really imperative for us to make sure that we're helping to develop a plan for that before it's necessary. Now, the term transition encompasses much more than just the transfer of care from a pediatric to an adult center, though that's oftentimes what our primary focus is on. But it's important to keep in mind that there are a lot of other things that can change as somebody ages too. Things like their access to services, their insurance coverages, oftentimes changes in school or day program. There are, depending on the patient's cognitive ability, there may be a focus on them increasing their own independence and engagement in their healthcare, and potentially a need for legal guardianship. So all of these things are going along and changing and posing some burdens at the same time as a patient is needing to leave their medical home that they really grew up in, and needing to find different providers. And so I think it's the most important thing for the pediatric providers to start a discussion and start that discussion early. What will transition look like? When will transition happen? Where will you go? What kind of people do you need to see? In some adult centers, there may be a need to see an adult neurologist in addition to an adult psychiatrist, in addition to a behavioral specialist, and identifying all of those needs and making sure that all of those structures and supports are set up before making the transition can really help ease that anxiety. And we don't want to add one more thing and one more burden for these families. So everything that we can do to try to make this as seamless as possible, and identify that competent care and making sure that the patient and their family really feels comfortable leaving their care home and moving on to a new one. And with that, I will turn it back over for objective 3.
Right, thank you very much, Tracy and Bethany. I think you really highlighted very nicely the tremendous impact that difficult seizures have on families, and also the very significant impact of the non-seizure symptoms of these developmental and epileptic encephalopathy. So the sleep issues, the feeding issues, the respiratory issues, so many of those. And then also the importance of really carefully planning for transition. So we're going to shift gears a little bit, and now we're going to talk about pharmacologic management of seizures in patients with developmental and epileptic encephalopathy. And we know now that there are many anti-seizure medications that are used both on and off label to treat these very challenging epilepsies. We don't have the ability to discuss all of those just in our limited time, but we are going to review some overall themes. And as well, we're going to address some knowledge gaps, really talking about the only agent that's approved for all 3 of these, for Dravet syndrome, tuberous sclerosis, and Lennox-Gastaut, and that is pharmaceutical grade cannabidiol. And so I'm going to turn this over to Adam to talk a little bit about how we might approach some of these DEEs.
Thank you. I think, as Elaine already mentioned, we are using quite a lot of drugs off-label in these conditions, as obviously they are rare and there have been really low evidence in the last 20 or 30 years. But now evidence emerged. And I think this is important to acknowledge that we have now class 1 and 2 evidence for newer drugs which were studied in a larger population. That means they were tested in 100, 200, or even 300 patients for each disease. So if we look at Dravet syndrome, we have usually a start on valproate and clobazam, but then next treatment steps are already cannabidiol, fenfluramine, or stiripentol. Also, there's good data on topiramate. The drugs behind that, there's very low evidence of use, and especially levetiracetam, perampanel, and brivaracetam might be associated with psychobehavioral side effects. Very importantly, in Dravet syndrome, be very cautious with sodium channel blockers, with gabapentinoids, so like pregabalin and gabapentin, but also tiagabine and vigabatrin can increase seizure burden and lead to status epilepticus. In LGS, it is a little bit different. So again, in the beginning, usually valproate with clobazam, maybe lamotrigine will be some mainstay, but then we have approved drugs like topiramate, rufinamide, and newly cannabidiol and fenfluramine. What's also available with evidence is felbamate, but because of the risk of aplastic anemia, this is on the back side of use, and other drugs like levetiracetam and brivaracetam, perampanel will have much more use. Also, sometimes sodium channel blockers like carbamazepine and oxcarbazepine can increase myoclonia, but you can give them a try. The same is the case for gabapentinoids and phenytoin. Data is different in TSC, as here we have class 1 data from RCTs on 3 drugs, and they're very different, obviously. One is vigabatrin, which was shown to be anti-epileptogenic, so that means it was used already in children with EEG changes, but not yet seizures, and shown that onset of seizure can be delayed, and maybe this will result also in better cognitive outcome. Then you have obviously everolimus, which is the drug interacting in the mTOR pathway. It's an immunosuppressant, so we have very different adverse events profile, especially with sore mouth and sore throats in the children. And then very well tolerated is data for cannabidiol, which was shown to be effective in a large study of more than 100 patients. Then you can also use other drugs. This will be mainly dependent on the seizure types. If you have more generalized onset seizures, then you might probably opt for valproate. Otherwise, any other drugs used for focal seizures may be used. Very importantly, these drugs have different effects on psychobehavioral and cognition. And this is important to take into account, especially in these 3 disease entities. I think importantly, what's good for mood and psychiatric is valproate, rufinamide, lamotrigine, and cannabidiol. These drugs can have positive effect, especially lamotrigine and cannabidiol and fenfluramine on cognition. Interestingly, all of them will make problems with sedation if you titrate too fast. Lamotrigine may be a problem for sleeping, but on the other hand, you have the possibility to use cannabidiol on perampanel with a positive effect. Pregabalin may be of use, but be cautious because it's one of the gabapentoids. And importantly, drugs like topiramate, levetiracetam, and brivaracetam, and especially perampanel, can have adverse events on behavior. Lamotrigine may be positively affecting behavior in those patients. Now I pass on.
As mentioned, CBD was first approved in 2018 for adjunct treatment of 3 developmental and epileptic encephalopathies, that is Dravet syndrome, Lennox-Gastaut syndrome, and tuberous sclerosis complex. There is strong evidence of efficacy in children, difficult to treat seizures. Although the underlying mechanisms of CBD are unclear, the identification of novel targets of CBD indicates multimodal mechanisms that include neuronal and non-neuronal, including microglia networks. CBD also has low affinity for CB1 and CB2 receptors, but it has other targets, including GPR55 receptor blockade, TRPV1 channel desensitization, adenosine reuptake inhibition, and then enhanced GABA release. Overall, CBD regulates network excitability and neuroinflammation, resulting in attenuation of seizure activity as well as comorbid signs. In addition, CBD has other actions within the endocannabinoid system, including anti-inflammatory, antioxidant, anxiolytic, analgesic, and neuroprotective activities, which might contribute to its overall protective effects. In view of such mechanism of actions of cannabidiol, it has broader implications with comorbidities such as hematomas, ASD, ADHD in children with these developmental epilepsies. A caution, these mechanisms are specific to CBD alone and do not translate to other cannabinoids like THC or even CBD in the context of other cannabinoids, including the whole plant extracts. Now, the important distinction between the CBD products that are available. So regarding the pharmaceutical grade CBD versus artisanal CBD versus medicinal cannabis, there are 3 critical differences in terms of purity, consistency, and accurate dosing. While there are other uses for medical cannabis, seizure control is specific to the pharmaceutical grade CBD only. The current challenge is to distinguish between FDA-approved pharmaceutical CBD products with other products such as medical CBD, dispensary CBD, which are widely available, because of significant variations in manufacturing methods, quality, formulation, and composition, which could influence the overall therapeutic outcomes. Patients' responsiveness to cannabis products vary due to many factors. Pharmaceutical grade CBD is a highly purified CBD, and it doesn't have any psychoactivity, has been federally approved for treatment of these 3 types of seizures. The evidence has arrived from the multiple randomized controlled trials and also from real-world studies. And it's a highly regulated product, highly standardized to guarantee purity, consistency, and accurate dosing. It is available by prescription through specialty pharmacies. In contrast to pharmaceutical-grade CBD, artisanal CBD is defined as hemp products containing less than 0.3% of THC. Therefore, they are likely to have some psychoactivity, and they are classified as agriculture products. They do not have any approved use for treating or preventing a disease. And there is no evidence for any translation of these products, and quality control, none. And they are widely available in the market. Again, in contrast to the pharmaceutical grade CBD, medical cannabis, which is widely available from a lot of dispensaries, it's a whole plant cannabis extracts containing a mix of cannabinoids. Therefore, it may contain THC and likelihood of psychoactivity. And the regulatory landscape is variable and complex, depends on the state where the dispensary is located. And evidence is very limited because there are no controlled clinical trials, therefore significant safety concerns. Quality control is often poor or none. And the legal status and logistical barriers depends on the state of these products' availability. Now, regarding the long-term safety and efficacy of cannabidiol, as you know, cannabidiol has been shown to be safe and effective in children with the DS, LGS, and TSC. Add-on cannabidiol was associated with sustained seizure reduction for up to 4 years. 4-year results from this expanded access program for treatment of resistant seizures are published recently. Treatment response rate, that's the main factor for both A, convulsive seizures, and B, total seizures, are shown in this picture. For convulsive seizures, the median reduction from baseline is about 50 to 67%. For total seizures, a median reduction was present between 46 to 66%. If you take a look at the overall seizure responder rates, a 50% or more reduction in seizures is observed in almost about 55% of the patients. And more than 75% of reduction in seizures was present in 40% of these patients across the time period. And seizure-free was achieved in about 15% of the patients. The most common adverse effects that occurred up to more than 20% of these patients include diarrhea, up to 33%, seizures, 24%, and somnolence or sedation in 23%. About 7% discontinued due to these adverse effects. Adverse effects were more common with concomitant use of clobazam, which is widely used to treat these diseases. Like 33% of these adverse effects were attributed to presence of clobazam, and then only 13% in the absence of clobazam. Note that clobazam, in the presence of clobazam, CBD does have clobazam-independent effects because of its likely pharmacodynamic synergism with clobazam. In terms of the liver function enzyme elevation was observed in patients with concomitant valproate use.
Right. And I mean, I think that this is really important. I know I'm going to go back one slide. Yeah, I think this is really important from the patient and family perspective because there's really not a lot of guidance out there. I know there's consensus opinions on things on how to treat Lennox-Gastaut syndrome specifically. I think we have a little more clarity in TS and in Dravet syndrome, but it starts to come down to these additional things. You know, when this drug first came out, the families were excited about the adverse event of diarrhea because our kids are all constipated, right? And then this Become study has been really nice because it's now started to talk about how you can have changes in non-seizure related outcomes without improvements in seizure outcomes necessarily, right? So CBD might have a positive effect on quality of life independent from the seizure outcomes. And sometimes that's what a family is looking for. You know, in the beginning of our journey, we're like, just stop the seizures. But by the time you get to the end of the journey and your kids had 40,000 plus seizures, you're just like, can you just give me some stability in life? The bar starts to drop and it's kind of sad. And so, you know, some families want no hospitalization. Some families want, you know, sometimes I think if you could just confine all the seizures tonight, that I'd sign up for that, like I'd stand in line for that medicine, right? And so it's really, this kind of gives us a chance to start thinking about what is important to families and how can we help. And so I think improvements in cognitive, executive function, language, that all came as a part of this were really, really telling and give us a level of guidance as families to think about what's important to us when we go along the journey. I'll just turn that back over to you, Elaine, now. Thank you.
All right, thank you. Well, thank you very much, Tracy and Bethany and Adam and Samba for the great discussion so far. So to summarize, we're going to summarize what we've covered today with our SMART goals, and we hope that you can apply these to your practice. We're going to then move on to the question and answer. So after today, we hope that you're going to be able to recognize and investigate early signs and symptoms of developmental and epileptic encephalopathies in order to achieve a timely and accurate diagnosis. We hope that you will routinely assess patient and caregiver quality of life because it really is about much, much more than the seizures. And so adapt care plans according so that you can address evolving needs and priorities there. And then importantly, educate patients and caregivers on the roles of pharmaceutical grade cannabidiol with a care plan. So we're going to go on to the questions. And so just to remind you to ask a question, if you can select the Ask Question tab below the slide viewer. And if you want to direct that to a specific faculty member, please do that. Or you can just ask it general as well. So maybe we'll go to some of the questions. So first of all, maybe I'll address this to Adam. Adam, how sedating is cannabidiol on its own without clobazam or valproate? And also, can you comment a little bit? We had heard from Samba that there is a drug interaction between CBD and clobazam. Can you comment on how you might manage that combination if you're adding CBD into somebody who's on clobazam?
Yeah, I think it's a very important question in clinical practice. If you use cannabidiol alone or with other drugs than clobazam or valproate, it is usually very well tolerated, and sedation is really kept to a minimum, especially if you are slowly titrating it up. If you have clobazam already taken by the patients, then be really careful because of this pharmacokinetic interaction. That means that the clobazam, especially the desmethyl-clobazam levels of the active metabolite, they will increase by the use of cannabidiol. And for that reason, and usually in my clinical practice, I will already discuss with the parents or caregivers to be already reducing clobazam levels once you start cannabidiol. I think this is important to acknowledge, and it will be probably even more a problem if you have a combination with valproate, and be aware that this interaction with clobazam is also the same for stiripentol. So if you have stiripentol in the treatment, then already the clobazam levels are higher than you would expect it if you used it alone. But otherwise, it's really good tolerated regarding the sedation if you don't have this clobazam point. And I think last point, don't start both at the same time. Do one thing at one time. So start clobazam or cannabidiol and then add the other drug. Don't do both at the same time. There's no reason for that, and you will only have adverse events with that.
Very wise words. Thank you. All right. We've had a couple of questions that have come through about barriers to get insurance coverage for drugs like CBD. What is the best method to get insurance coverage? Bethany, are you able to speak on that, or one of our other panelists?
Sure, I'm happy to take a stab at it. I think a lot of it will depend on insurance coverage, and knowing that a lot of these patients will have state insurance. A lot of the insurance coverage will vary state by state. Many of the pharmaceutical companies will have their own team available to assist with copay coverage and bridging access to medications for those who need it. And I would say I'm in Pennsylvania. The state-based coverage ends up being quite good for these, but that's not always the case. And so leaning on the right supports to address that. It's certainly not one size fits all, but the support and structure is there through many of the companies.
Great,
I would just add to, don't hesitate to connect families to the Dravet Syndrome Foundation, the Tuberous Sclerosis Alliance, or the Lennox-Gastaut Syndrome Foundation. We spend a lot of time helping families get access to their particular situation, and we've got 7,000 families all across the world, and there might just happen to be somebody in that city, in that state, with that insurance that knows how to navigate it. And most of our families can usually get what they need if they have a doctor that's willing, but it is always a battle. It seems to be always a battle.
Great, thank you. So the next one, Tracy, I'm going to address to you, and if you can talk, and I know you have your own experience, but I think you have a lot of experience from other families. So the difference in Lennox-Gastaut is what you see in children compared to what you see in adults as far as symptoms. Can you talk a little bit more about that?
Right. In children, I think that by the time we get the families, they've already seen quite a few seizures at this point. They've already got intractable epilepsy for the most part, more than one seizure type, right? And they're probably beginning to see delays because within a year of the LGS diagnosis is when the delays are present. They're not always there at the time you see the slow spike and wave. We see the slow spike and wave in children, but that disappears in about half of adults. But then GPFA, the paroxysmal fast activity, is present in almost everybody, not in the very beginning, but within, about a year or two after the slow spike and wave, and then it continues on into adulthood. So I think that EEG finding is really prevalent. And then I think the mindset shifts of the family. You've got a really young child who's having a lot of seizures, and you can scoop them up, and their physical disabilities are a little bit more manageable. But then that child gets older, and now, it's no fun changing a 30-year-old's diaper, right? It's not, it's not as easy anymore, and putting them in a wheelchair and mobilizing them around, and if they need oxygen, or if they carrying around all these rescue meds. So I think the mindset of the family changes. I also think that you have to think about, like in LGS, the etiology that you're dealing with. So we have kids who have Down syndrome that have Lennox-Gastaut syndrome because they develop seizures that then evolved into LGS. And they have a lot of skills compared to some of our other LGSers. We also have kids with like lissencephaly, so like smooth brain syndrome, that have Lennox-Gastaut syndrome. So they had much more of a disability in the beginning. And I think this is why the etiology is so important, because you've got the LGSs on top of the etiology. And so putting those together, so you might see some really young kids that are less severe, and then older kids, and then young kids who are like, my daughter was like typical when she was diagnosed with it. So, but the journey does change. And I do think it starts with, what is it? Where did it come from? And then it quickly goes to, how do we stop it? And then it eventually goes to, oh my gosh, how do we live with it? And then it becomes, how do I keep navigating this when we've tried everything, and the kid's getting bigger, and now they're an adult and the world doesn't know what to do with them. So, so I think keeping that in mind, and that it's a journey for the whole family, is important as well.
Thank you. And you had mentioned also that sometimes the EEG does evolve, does change. And so one of the questions, and either you or maybe Adam can take that, is the definitive diagnosis of Lennox-Gastaut possible when it's delayed beyond the point of that characteristic EEG? So maybe you're not seeing that slow spike wave anymore, or how do you make the diagnosis at that point?
I mean, I'm going to let Alex talk about diagnoses because he's a doctor. And then if you still want to hear about what we see in the community, it's the Wild West.
All right, Adam, do you want to take that?
Yeah, I think a very important point is to not to leave anyone behind. It means if you don't see the typical features on the EEG, but you have, some cognitive delay, you have onset in childhood or adolescence, and you have especially drop seizures, then this is very indicative of Lennox-Gastaut syndrome. And I think you don't have to be definitely sure. I think if it's probable, then you should diagnose, and then also to try the drugs approved for it, because this might make a big difference in this population. If you stop the drop seizures, this is a dramatic improvement for the families. So for that reason, don't be shy to diagnose it. You can use the drugs, and if they don't work, you can still stop them after 3 or 6 months. So I think it's for our patients, we should be very alert to look if someone might have an LGS, and ELIE recommendations. They have put up the upper limit for onset up to 18 years of age. So they have broadened the access to the diagnosis.
Yeah, and sometimes I think you can look back, right, and you can try and get EEG records, but those may or may not be available. So
And I would just add, we see that in the LGS community as well, where if you have LGS-like, you're invited in our community of support because you're living the same life, right? You want the same medicines. You're going to try to get access to the medicines. And just because you couldn't find your EEG, your kid's, 13 now, and you can't find that EEG that said so spike and wave, shouldn't, prohibit you from getting access and getting support. But even if they're LGS-like and they don't have all the features, they're welcome in our community of support. We are not the DEE Foundation, but they are welcome over here.
That's great to hear, Tracy. Thank you. And I have a question. I think I'm going to direct this either to Samba or Adam. And it's a question about people who are on valproic acid and you're wanting to switch to CBD. And so the question is, when can CBD be used after stopping valproate, or can you start it together with valproate? And I think talking a little bit about the potential transaminitis that sometimes we can see a little bit more commonly with that. So I don't know, Samba, if you want to address that, or Adam?
Yeah, I think my understanding is that the liver enzyme induction happens if valproate is already stabilized. So if you're adding, definitely CBD is an add-on. So if you're adding patients who are already taking valproate, there is a possibility of some substantial enzyme induction. But the clinical significance will all defer to Adam to comment on that.
Yeah, I think it's quite easy. If you stay below 10 milligrams per kilogram, even from the RCTs, but also from my clinical practice, you will mostly don't see any liver enzymes elevation. So if you start slow, don't worry about that. You make the labs and then everything will be fine. I think you have to be careful if you keep valproate and you increase cannabidiol up to 20 milligrams per kilogram, then look at the liver enzymes, but up to 10, which is the normal dosage, everything will be fine.
And I think importantly, right, it's shown elevated transaminases, but nobody has gone into liver failure. So I think it seems to be an isolated elevated transaminases, and they usually come down to normal again. So we're just actually about out of time. So I'd like to thank our panel for a great discussion. And I'd like to thank the audience today for being so engaged and sending in those wonderful questions. To receive credit for today's activity, please complete the post-test and evaluation and click on the Request Credit tab. And don't forget to visit the Virtual Education Hub at cmeoutfitters.com for more free resources and education for healthcare professionals and patients. Thank you and have a great night.